It's good afternoon, good evening, good morning, everybody. Welcome to this symposium SP12, which is about scale up of joint action on diabetes and tuberculosis lessons from the field. I'm one of your co-chairs today. My name is Tony Harris. I'm senior advisor at the International Union Against TB and Lung Disease, and I'm also an honorary professor at the London School of Hygiene and Tropical Medicine. And I'm delighted to have with me Rafael Lopez Solarte, who will also now introduce himself.
Yes, good morning, good afternoon, everyone, wherever you are. My name is Rafael Lopez. I'm advisor for TB prevention, control, and elimination at the Pan American Health Organization, Regional Office of the World Health Organization for the Americas. Welcome.
Right, Rafael, if you introduce the first three speakers, I'll introduce the last two speakers.
Yes, when we have the first three speakers are Annabelle Batley. She is the technical officer in the vulnerable population communities and comorbidities unit at the WHO Global TB Program in Geneva, where she has been working since 2010. The title of her talk would be Global Status on the Uptake of the UN WHO Collaborative Framework for the Management of TB and Diabetes. We also have with us Mohamed Yassin, who is the Senior TB Advisor at the Global Fund based in Geneva, and he advises the Global Fund leadership teams and countries implementers on strategic investment of resources to support priority interventions, populations, to maximize impact. He provides technical leadership during development of funding requests, policies, and strategies, and works closely with global and regional partners to improve coverage and quality of TB, DRTB services. The title of his talk would be Assessing Comorbidities as part of High-Impact Interventions in Global Funding Requests and Grants. And we also have Auran Saib Qadir Balak, who is the National Manager of the TB Program of Pakistan since 2017, and he has successfully managed transition and devolution of TB care to the provinces. He has initiated many new endeavors in the country, including involvement of primary healthcare in TB, the centralization of MDR care at district level, and universal GP coverage by implementing mandatory TB case notification in the country. The title of his talk would be Challenges, Enablers, and Plans for Scaling Up Integrated Action on TB and Diabetes, Lessons Learned from Pakistan. Now, Tony will continue presenting the other two speakers. Tony?
Thank you, Rafael. So our fourth speaker is Denise Arakaki Sanchez. She's technical advisor at the National TB Program in Brazil, and she is also coordinator of the Reference Center of Infectious Diseases of Brasilia. She was formerly the National TB Program Manager in Brazil for 4 years. And the title of her talk will be Experience of Initiating TB Preventive Therapy Among People with Diabetes in Brazil. And our final speaker is Dr. Charles Sandy. He's Deputy Director in the Directorate of HIV, AIDS, and TB programs, and he leads the National TB and Leprosy Program in Zimbabwe. He's done this since 2006. He's also been actively involved in Zimbabwe in operations research and has led the implementation of Zimbabwe's National TB Prevalence Study, the National Drug Resistance Survey, and National TB Patient Cost Survey. And the title of his talk will be Introducing Diabetes into TB-HIV Collaboration, Opportunities and Plans for Addressing Multimorbidity in Zimbabwe. So before we get on to the presentations, which will run continuously now, I'd just like to explain the Q&A. When you look at the presentations, on the right-hand side, you will see 5 icons, And the fourth icon, if you click on it, says questions and answers. So if at any time during the presentations or during our Q&A session, you would like to ask a question, just type it, and then Raphael and myself will note it. And when the presentations are finished, we will put the questions together, and we will basically ask the presenters if they can give answers to those questions. So thank you very much. I think we've done the introduction, and we'll go on now to the presentations.
Hello, I'm Annabelle Badley from the Global TB Programme at WHO, and I'm introducing the session with an update of the global status on TB and diabetes, as well as the uptake of the collaborative framework by 30 high-burden TB countries. So I have no conflict of interest to report. So diabetes is a very key driver of tuberculosis, and in 2019, an estimated 350,000 cases of TB were attributable to diabetes. That's about 3%. You can see from this map that actually, you know, the percentage varies across the countries, and in high burden countries, there is a high percentage, higher than 5%, and, you know, in some countries even higher than 10%. So the 2016, the latest 2016 report, global report on diabetes, estimated 422 million adults with diabetes and 1.5 million deaths. And the worrying thing is diabetes is highlighted as being on the rise. And the issue is also that diabetes is on the rise in high TB burden countries, and you can see here the top 30 high burden countries where it's on the up. And this is really an issue in terms of diabetes as a key driver for TB. And we also have an issue in these countries because the basic technologies for testing for glucose, blood glucose levels, as well as availability of insulin in the public sector and primary healthcare are not available. And poorly managed diabetes is an even higher risk for TB. So this is something that could be seen also as an opportunity, but it is a real threat. So what's the evidence say? Well as 2 to 3-fold increased risk of TB, diabetes is associated with poorer treatment outcomes, including double the risk of death during TB treatment, and also 4-fold risk of TB relapse after TB cure or treatment completion, and also a 2-fold increased risk of MDR-TB. Now, this really highlights the fact that it is very important to find TB amongst people with diabetes, but also that's for finding missing people with TB, but also to find diabetes amongst people with TB to ensure that the treatment outcomes are improved and that there is a reduced risk of going on to developing MDR-TB. So in 2011, WHO and the Union released a collaborative framework on TB and diabetes, similar to the TB-HIV collaborative policy. And this is largely focusing on 3 objectives: to establish mechanisms for collaboration, to detect and manage TB with in people with diabetes, and to manage and detect and manage diabetes in people with TB. Pillar 1 of the NTP strategy really has a strong focus on integration, patient-centered care and prevention, and of course really highlights the importance of including addressing comorbidities within the holistic and comprehensive care of TB patients. at the respective UN high-level meetings in 2016 and 2018 for TB, HIV, and NCDs, there were also clear commitments made by member states to strengthen integrated care for diseases like TB, HIV, and diabetes, as well as other related risk factors. So where are we in terms of scaling up or implementing this joint action on TB and diabetes? WHO has been doing a review of national strategic plans as well as guidance to see in 30 high burden countries to see how aligned it is with WHO guidance. Publications being reviewed are the national strategic plans for both TB and NCDs, as well as the guidelines for TB, diabetes and NCDs, etc., and all the other comorbidities as part of this review. The sources have been the Global TB Program database, as well as other resources such as the NCD document repository at WHO and the country planning cycle database, as well as others for the other comorbidities. So preliminary analysis from the national strategic plans for TB in the 30 countries showed that there was just over half of countries are actually planning on case finding for TB in people with diabetes. And this is probably to do with efforts to find missing people with TB. Worryingly, there's less focus on management of TB in people with diabetes within the plans, and also only 13 countries looking at case finding of diabetes in patients with TB. 11 of the NSPs actually included bi-directional screening, which was good, and 9 NSPs encouragingly included at least one indicator on TB and TB diabetes activities, showing that they're actually intending to measure their implementation. The preliminary analysis of the NCD NSPs is really less rosy, let's say. 9 NSPs highlighted the importance of the association between TB and diabetes. However, very limited countries actually included TB and diabetes activities within their planning. Tanzania, interestingly enough, was a good example that sort of seemed to report on all areas, including at least three indicators on TB and diabetes within their NSP for NCDs. So there are limitations here. The scope of NSPs, particularly for NCDs, is quite broad, and review of their guidelines and policies will obviously provide more granularity. We also can't tell, I mean, there is a mismatch between the NSPs, and it could denote lack of collaboration or lack of engagement from one side, or it just may be the way they have agreed to do their planning exercises. Also, planning doesn't necessarily mean implementation, particularly in an era where resources are limited. So, summary of the opportunities and the summary of the findings and opportunities. There's limited inclusion of collaborative action on TB and diabetes in the NTP national strategic plans, and close to none in the strategic plans for NCDs. There's a mismatch between TB and NCD NSPs within the countries, and the NTP plans tended to be more action oriented than the NCDs. But also, there is an opportunity because the number of the NSPs need to be updated, so we can support countries to really ensure that TB and diabetes are within them. We can also, there is the opportunity of leveraging efforts and resources to mitigate the impact of COVID-19 on both TB and NCDs, and this could be as part of an integrated within the primary healthcare platform. So the way forward, WHO will be reviewing the completing the review, including national guidelines for TB and NCDs, and we'll be disseminating those findings as we go. We'll also be supporting countries to update their NSPs. We're developing a framework for action on TB and comorbidities in the context of universal health coverage to provide a more holistic approach to patient care, as well as a roadmap on TB and comorbidities with key stakeholders. And we will continue to mainstream TB and diabetes policy within our respective global policies, and we'll continue to promote tools to support integration. We'll also be working to work more closely with other diabetes stakeholders and civil society to really highlight the opportunities for joint action, and also to strengthen the demand. So here are some resources to support implementation, including the Guide to Essential Practice that the Union brought out in 2019 to support implementation of diabetes and TB. And as well as there's a joint pre-qualification program that countries can have access to, and also the Diabetes and Management of Type 2 Diabetes HEARTS-D, which is supporting countries to integrate diabetes within primary healthcare, and these can be adapted to TB settings as well, TB services. So with that, I'd like to acknowledge the people listed here: Rachel Beanland, Anthony Harris, Ernesto Jaramillo, Goika Roglic, and Sherian Varghese. So thank you very much.
Thank you very much. My name is Mohamed Yassin. I'm a Senior TB Advisor at Global Fund based in Geneva. I will be presenting on addressing comorbidities as part of the high impact interventions in Global Fund funding requests and grants. Just a quick overview of the Global Fund investments, result, and impact. The data presented in this slide already revised because the result report published this month, which actually shows that the Global Fund investment so far contributed to saving 38 million lives. That's 6 million additional lives saved in 2019 compared to the 2018. And the supports include the $3.5 billion in 2019 for over 150 countries for TB, HIV, and malaria. And specifically for TB, Global Fund is a major funding source for international funding source, accounting for over 73% of funding for TB in low and middle income countries. That contributed to diagnosing and treating 5.3 million people with TB in 2019 alone. So the Global Fund is contributing to ending TB and working with countries and partners to make sure that TB service reaches the people who need the service. So looking at the opportunities to address comorbidities within the Global Fund investment, where comorbidities and co-infections, which would directly or indirectly affect the morbidity and mortality of these for TB, HIV, and malaria, could be supported through Global Fund resource. There are opportunities to actually maximize the overall support for these comorbidities, which are relevant for the Global Fund investment and resource and support. The first one is a Global Fund strategy, which actually calls for maximizing the impact of the TB, HIV, and malaria service to end the three epidemics. Also supports building resilient and sustainable systems for health. And there are other strategic objectives, including addressing human rights barriers and gender equity, and raising more funding. These are the four strategic objectives of Global Fund. But within these objectives, you see that the Global Fund is prioritizing its investment to address key and vulnerable populations, have high risk of getting the disease, or high risk of mortality and morbidity from TB, HIV, and malaria. Specifically for TB, we are talking about the high risk TB population, including people with comorbidities and co-infection. And Global Fund also has a policy on co-infection and comorbidity supporting, specifically for TB. This includes people with diabetes, cirrhosis, tobacco use, and people with autoimmune disease and malnutrition. These comorbidities have impact on overall TB either contributing to progression of latent TB to active disease or vulnerability to exposure and infection, and also increased vulnerability or risk towards poor treatment outcome for TB. That's why the Global Fund has a policy on addressing this comorbidities and co-infection. Global Fund also have a TB information note which provides guidance on high impact interventions, including prioritizing key interventions for high risk group, including people with diabetes and other immune suppressing conditions. This is the part of the policy on co-infection and comorbidity, where a Global Fund investment should be supported by evidence and prioritization, and the investment should contribute to overall impact and should also be value for money. And the investment and the support should also contribute to reducing mortality and morbidity to the 3 diseases, including reducing morbidity and mortality from TB by investing or addressing comorbidities, including diabetes. And it's an effective health intervention which should also be supported to prevent and treat comorbidities, which disproportionately affects people with the 3 diseases. Here we are talking about diabetes as an example, which disproportionately would affect TB patients or progression of TB infection to disease and the outcome of TB treatment. That's why there is already relevance here to support diabetes patients and people with other immuno or suppressing condition as part of the TB investment as well, because this will contribute overall improving on TB service delivery and accelerating the ending TB. The financial support for comorbidities could be leveraged through the allocation or a grant, which are already supporting country implementation. This could happen anytime, and it could be savings, efficiencies, or reprogramming of some of the interventions. This could be the source of support for comorbidities. As far as these comorbidities are prioritized ones and would contribute to improving TB service. And the second option, which we have, Global Fund already allocated additional funding to selected countries to implement some key interventions which may not fully covered through allocation. This would be this considered as a catalytic funding, and a matching fund is in addition to the allocation. Matching fund is provided to countries specifically to address specific issues. For TB, it's the main issue has been to address the millions of people who are missing, the millions of people with TB and drug-resistant TB missing from the system and not receiving the service. And this catalytic matching funding would contribute to addressing these patients. And this requires mapping of those missing people, who they are, why they are missed, and where they live, and how we can reach them. And that exercise, you see that people with high risk would be one of the areas where integrated services needed to address TB among people with high risk for TB, including diabetes. And we also work with, as part of strategic initiative with partners, WHO and Stop TB, to support countries to implement those activities to find the missing millions. And the third one is a portfolio optimization. This is where Global Fund pulls all the money which are not used by countries and then redistribute to address some key interventions and redistribute to countries which are utilizing their resource and need more resource wherever there are more gaps. And this is another opportunity where we can leverage more resource. And so far, I think Global Fund now is accepting all the funding requests for the next 3 years. As you may know that we had a very successful sixth replenishment with over $14 billion pledged for 3 years. And Global Fund already allocated this money to countries, and countries are now requesting funding to Global Fund, and the majority of the countries have already submitted their funding requests for the next 3 years. Despite this difficult situation due to COVID, countries have managed to prepare funding requests and submitted, and the technical review panels of the Global Fund have reviewed over 3/4 of the funding requests already. And we have seen in some of these requests and TB funding requests, addressing diabetes and TB already incorporated in some of the countries where TB screening and diagnosis treatment among people with diabetes already included. and the funding request to support those interventions as part of comorbidities and as part of integrating service with other interventions which are of relevance to ending TB. And country prioritization should be based on evidence, and the decisions at the country level very important, because the argument for support for comorbidity should be incorporated and presented, and this may require doing further assessment and survey of the risk of having TB or having unfavorable outcome of treatment of TB among different groups should be presented. And as far as those arguments and evidence data-driven are presented, there are opportunities to incorporate this as part of the TB support. And we would like to encourage national TB programs and stakeholders at national level and regional and international level to explore opportunities within the Global Fund supports for comorbidities. And because the current Global Fund model provides flexibility so that any critical interventions to be incorporated during funding request development, grant making, even during implementation. So that flexibility is available, and all the stakeholders, MTPs, are encouraged to discuss with the country teams, with the Global Fund country teams, to explore opportunities to maximize, utilization of this investment for comorbidities, as these are relevant. And this is becoming more relevant now with COVID and its impact, and Global Fund is also providing support to countries to respond to COVID, but also to mitigate the impact of COVID on TB as well. That's what I want to share with you. Thank you very much again. Have a good day.
Good evening. I am Dr. Aurangzeb, National Manager, NTP Pakistan. I have no conflict of interest to report. My topic is Challenges, Enabler, and Plans for Scaling Up Integrated Action on TB and Diabetes. Lesson learned from Pakistan. TB and diabetes in Pakistan. Pakistan ranked 5th among the high-burden TB countries. The incidence of TB is 263 per 100,000 in 2019. 7th highest burden for diabetes in Pakistan. Diabetes mellitus increases the risk of developing TB and contributes to adverse TB outcomes. Screening and integrated management for both disease in high-burden countries is suggested. So this is study number 1, where the patient screened for diabetes at TB clinic in KP province in April 15 to September 17. So here we can see that a number of patients screened, then they were tested for random blood sugar and fasted blood sugar, which shows that the prevalence of diabetes in TB patients is around 16%. Similarly, the screening of tuberculosis in the diabetic clinic shows that among the presumptive TB, the diabetes was around 30%. The study number 2 and 3 is the diabetes mellitus among tuberculosis patients. A cross-sectional study conducted in the pulmonology ward and OPDs of Khyber Teaching Hospital in 2017 showed the frequency of diabetes in patients with pulmonary tuberculosis was 16.2%. Another similar study conducted in Lahore in 2015 showed the prevalence of 14.8%. So in this study number 4, the association of diabetes mellitus with the treatment outcome of DRTB in Pakistan from 2010 to 2014. So we can see that the favorable outcomes without diabetes was 69.3% and with diabetes was 66.4%. The cure was 66.6% without diabetes and 65% with diabetes. Unfavorable outcomes without diabetes were 30.7% and with diabetes were 33.6%. So the failure was 4% and 3.9% with and without diabetes, and it's negligible. The action plan and recommendations: a high yield of TB identified among diabetes with a high yield of diabetes mellitus among TB patients. The screening testing is very low among these population. bidirectional studies for TB and diabetes, which includes the integration of TB diagnostic, diabetes screening, and TB diabetes treatment within existing healthcare program need to be addressed. A large number of diabetics were newly identified, suggesting the need for implementation of collateral active case finding initiative for diabetes mellitus. The national guidelines should be revised, that is, HbA1c should be done for the patient with diabetes every third month to monitor diabetes mellitus management. However, more research and evidence is required to determine optimum therapeutic options for comorbidity in individuals, effect of glycemic control on TB treatment outcome, and developing an integrated mechanism to cater for the need of newly diagnosed diabetics and tuberculosis patients. Thank you.
First of all, I would like to thank the organizers for keeping this conference, so important conference, alive in this pandemic time. I know it's a big challenge for all of us who work on TB and other pulmonary diseases. So my presentation is about the experience of the Brazil on LTBI treatment and its interface with diabetes. This is my session and I have no conflict of interest to declare. So my first slide is to speak about the TB and diabetes importance in the world. The estimates indicate that 80% of all diabetes patients take place in the low and middle income countries. As you know, Brazil is a middle income country. And the researchers also warn that the world will experience the very important increase of diabetes in the TB, the countries with high incidence of TB in the next 30 years. And you know, the Brazil is in the list, the 30 list of the high burden countries for TB from WHO. In a very simplistic way, what we can say about the perspectives of TB and diabetes in Brazil for the next years is, you know, that we are experiencing economic crisis since 2014. And now we have the situation more worsened because of the pandemic, COVID-19 pandemic. So this both situation can bring impoverishment of the population. In what it will happen with the Brazilians is that we'll face less access to health services, we will have a decrease of quality of life, unemployment, and we will see worse conditions of health. And both the situation can bring more obesity, more diseases, including the contribute to occurrence of TB and diabetes in the next future. So this slide is only to show the TB and diabetes in Brazil. I used 2006 as the first year for the comparison because the 2006 was the first year of the Vigitel survey. Vigitel survey is a national survey based on telephone, and they call the families in the 26 capitals of the Brazilian states and the federal district to see about the situation of the health, especially related to chronic non-communicable diseases. So in 2006, from 2006 to 2019, we can see a decrease of the incidence of TB. And the other side, we can see an increase of the prevalence of diabetes. And we see in diabetes an increase of 34.5% in total. That means diabetes is, as previewed by the researchers, diabetes is getting a big place in our epidemiological scenario. This slide is only to show a decrease of TB, pulmonary TB incidence in the country in the last years, and we see at the same time an increase of TB and diabetes, pulmonary TB and diabetes associated, an increase of the number, this rate. And here we can see the women seems to be more affected by TB and diabetes. And here we can see the age, the people over 60 years old is more affected by TB and diabetes. In this email, in this slide, I would like to highlight the the diabetes TB and diabetes clinical outcomes. It's curious because in Brazil, diabetes could be a protection for TB patients. We can see a higher incidence cure rate and less deaths and less defaults in TB associated with diabetes. We have many hypotheses for this fact. Maybe we would say that diabetes patients are used to take care of themselves. They are familiar with the recommendations. They follow the recommendations. They adhere more to the clinical recommendations, and they have stronger links to the health units. So maybe this population is able to follow the instructions, and that's why they have best outcomes, clinical outcomes when you have TB and diabetes. Going back to TB, specifically for LTBI, until 2010, the TB prevention recommendations were based on vaccination of newborns with BCG, LTBI treatment in people living with HIV, and assessment of children under 5 who are household contacts of pulmonary TB cases. Even so, I think the main objective of the context evaluation was to find early the TB active cases. So after 2010, in 2010, the NTP launched a new recommendation about the LTBI, including adults, asymptomatic adults as a household contacts to be screened for LTBI, and once positive, these adults should be treated. And beside the adults contacts, the NTP include other groups like renal, chronic diseases, diabetes, malnourishment, immunosuppression, among others. And in 2018, the NTP launched a new protocol about LTBI surveillance. This protocol wants to scaling up the access to diagnosis of LTBI and treatment of LTBI. And at the same time, the NTP launched an electronic system to register the new LTBI patients on treatment. To date, about the LTBI strategy in Brazil, we have 24 out of 27 states, Brazilian states, they are trained and able to use the electronic system. It's important to remind that this implementation is not at the same time, because the NTP trained state by state. Although they have the capacity, the 24 states are able to use the system, the adoption of the strategy is not homogeneous. So we don't have a national data. But what we have until now, since the starting implementation of this LTBI system, is that I extracted the data from September, the beginning of September of this year, and we have until September 36,000 patients under treatment of LTBI. We see only 0.5% of the patients were treated due to diabetes. That's interesting to see that the TNF-alpha inhibitor users are the third group, and this drug is very recent in the Brazilian health system, and they already have this third place. So it's curious because diabetes in our community a long time, and TNF-alpha inhibitor users is very recent, and they have attention of the healthcare workers. As opportunities and lessons learned from the LTBI implementation, we can say the TB and diabetes, even they share the same health system, they don't receive attention from the healthcare workers. I don't know the exact reason, but it's funny because, as I mentioned previously, the TNF-alpha users is more in the mind of the healthcare workers. And we have a lot of opportunities. In average, the healthcare units assist patients, 5 TB patients per year, while they are responsible for 300 diabetes patients per year. So diabetes activities is more present, is in a day by day in the health care facilities. So the TB could piggyback on diabetes activities would be a very interesting way to keep the TB activities alive. So I think we have to explore this discrepancy between how many patients I have on diabetes and how many patients I see with TB in the healthcare facilities. If we also include integration with women's health program and the elderly program, I think would be very fruitful for the both programs to avoid the TB disease in the elderly and the women. And we see the women is very addicted to the health recommendations in our country. So this is what we have until now about the LTBI and diabetes. And we, although the database is very recent, we can use this data to try to build a more integrated work plan between the diabetes programs and the TB programs, not only the national level, but including the local level. That's my message, and thank you for your attention.
I'm going to talk about TB, HIV, diabetes mellitus care from the Zimbabwean perspective. I don't have any conflict of interest to declare. Looking at Zimbabwe, this is a country in the southern part of Africa with a population of 15 million. Zimbabwe has got a high burden of TB, HIV, and drug-resistant TB, a high burden of HIV, and a relatively low burden of diabetes, mainly because we think there is underdiagnosis. We have to consider the risk of people living with HIV in terms of TB, the risk of diabetes in terms of TB, and the impact of art on diabetes amongst people living with HIV. And because of all these associations, there's need to have an integrated approach to the three conditions. This is the picture of the key impact indicators on TB for Zimbabwe, where we are seeing a decline in incidence, a decline in mortality, and this is mainly due to a number of measures related to diagnostic access improvements, capacitation of healthcare workers, and the impact of universal ART. This is the screening pilot, which culminated in a publication of a study. This was done over a period of 1 year in Zimbabwe and Uganda. It was funded by the World Diabetes Foundation and implemented through the union. We had 10 high-volume polyclinics as the pilot sites in Harare, and the project goal was to improve diabetes mellitus case finding amongst TB patients and vice versa. So the rationale is very clear. We know the high risk of TB disease amongst diabetics. We know the fact that the diabetics are more likely to get bacterial confirmed TB, which is more severe, and also have a higher risk of death during treatment, higher risk of relapse, higher risk of treatment failure, and higher risk of developing drug-resistant TB. And this is also associated with worsening glycemic control and complications in people with TB, with diabetes if they get TB. We know there's no evidence of feasibility in our setting, and we wanted to generate new evidence. We know that this has been happening in other settings, especially in India and China. The project started off with initial stakeholders meeting, the development of guidelines, SOPs and M&D tools, capacity building of healthcare workers, and then the actual implementation, which was also fully monitored and evaluated on a regular basis, and also the operational research. These are the results in terms of the approach when screening for diabetes amongst TB patients. We're using symptom screen first, and those who are positive on the symptom screen would then undergo a random blood sugar. If it was above or equal to 6.1 millimoles, they were declared as presumptive diabetics and would go on to have a fasting blood sugar. And if this was greater than or equal to 7 millimoles per liter, they would then be considered as confirmed diabetic. For TBs, what we did was that all diabetic patients on treatment would have either a symptom screen and or a BMI assessment. If it was less than 17, they were considered positive, and or an abnormal chest X-ray. So if the symptom screen was positive, that patient would then be requested to submit a sputum for examination by a gene expert. These are the summary results of the screening. In terms of screening for TB patients for diabetes mellitus, we screened 1,617 patients, and we identified 111 new cases of diabetes. The number needed to screen was 12. In terms of screening of diabetic patients for TB, we screened a total of 510 diabetics and diagnosed 25 cases of TB, and the number needed to screen. These are the characteristics of the patients. We're looking at sex. There were more males in the TB clinic compared to the diabetic clinic. When you look at age, the median age in the TB clinic was 37, and in the diabetic clinic it was 63. When you look at HIV status, the proportion of patients who were positive was higher in the TB clinic than in the diabetic clinic. When you look at ART duration in the TB clinic, the proportion who had been on ART for less than 2 years was significantly higher compared to the proportion in the diabetic clinic, who were only 22%. So in implementing this pilot, we noted some number of barriers, one of them being delays in getting the project off the ground. Then there was also the lack of one-stop shop approach for the diabetic patient cascade, because they had to be referred to a high-level hospital for fasting blood sugar. There was inadequate funding for diabetic medicines and consumables for the screening. There was also delayed availability of recording and reporting tools, and initially healthcare workers did not like the intervention because they felt it was additional work. We also noted some implementation enablers, some of them being the strong ownership and communication by the local health staff and managers, the availability of appropriate M&E tools to capture essential data, regular performance monitoring was also good, availability of IC materials, the adequacy of pilot personnel available, the availability of diagnostic services, and also the availability of adequate stocks of medicines. And lastly, the availability of a high-quality TA from the World Diabetic Foundation and the Union. Now, following the pilot, we rolled out the intervention to other sites. We started off with 10 in 2018, increased to 29 in 2019, and provided the implementation sites with all the requirements. However, the yield in the rollout was not as high as in the pilot. For example, for diabetes, we only managed to get 38 cases of diabetes, and the number needed to screen was 115. Similarly, for TB, we only managed to diagnose 21 cases, and the number needed to screen was 102. However, despite the initial experiences, we think this is something that we need to scale up further And we have also now added this intervention to the National Strategic Plan, and we are also planning to incorporate other comorbidities in this integrated approach. And we hope that we should also be looking at other conditions such as alcohol abuse and undernutrition, which are great opportunities for further integration. As conclusion, this bi-directional screening of TB and diabetes is feasible, it's high yield, and is cost-effective within primary health care settings. The third scale-up of the intervention is in the national plan, national strategic plan, and is underway. The barriers can be addressed through collaborative efforts by relevant departments and stakeholders. We also think there is need to consider layering in this intervention in existing TB, HIV integrated services. There's need to provide regular support, data-driven supervision and mentorship for success, and also ensure consistent availability of consumables. I would like to thank all those who participated in getting this pilot done and rolling it out to the other sites in the country.
Thank you very much to all the presenters. We would like to now move on to some questions and answers that people have been posting. So we would go with a first set of questions. The first one is an anonymous question saying, good evening from the Philippines. In a TB clinic of one of the places where I'm in the physician, most of our primary drug-resistant TB patients, not a retreatment case, are diabetics. This is not the pattern we see for our drug-susceptible TB cases. What could be the explanation? I would like to direct this question to Charles, please. What would be the response to this question? Over. Dr. Charles? Dr. Charles, if you can unmute your microphone, please.
Okay. If I got the question correctly, was the differences in the diabetic prevalence amongst retreatments and
The question is, why is there a difference between drug-resistant and drug-susceptible with respect to comorbidity with diabetes?
Sorry, my internet is collapsed. Can you send me the question? Sorry, can you just type the question? I can't get anything. The sound is very poor.
Okay, I'll repeat it once more. A question from the Philippines asking what is the difference, why is there a difference between the drug-resistant TB patients and the drug-susceptible TB patients with respect to comorbidity? That they see more comorbidity of MDR TB and diabetic cases than in drug-susceptible cases in the Philippines. What would be the explanation? Over.
Okay, let me try. We don't have much experience with drug-resistant TB amongst our cases in the pilot as well as in the field. Our burden is low, but I think the major reason why we could have a higher burden in the Philippines of diabetes could be the issues of drug-to-drug interactions. I suspect, I cannot say exactly why. And also probably the issue of the diets and the genetic disposition. It could also be some of the issues that might explain the difference.
Okay, thank you very much. We move to another question. This is from Barshat Thapa. Is bidirectional screening only a collaborative intervention? Is there any specific treatment interventions to comorbid conditions? Is the WHO advised to conduct diabetes mellitus tests to all forms of TB cases or smear positive cases only? Annabelle, could you take this question, please?
This is, the sound is terrible, actually. I don't know whether, I hope you can hear me. I think the question for the framework, the TB and diabetes framework, it's actually, it covers co-management as well of TB and diabetes. Of course, you know, so if TB is found amongst people with diabetes, then of course there should be treatment, and depending on the situation, whether it's integrated, actually treated there, or there is referral, that is another situation, and you know, obviously it's better to promote as at the same time in one place as far as possible, but understanding the health system's differences. And in terms of all forms of TB, I saw that in the chat actually. There was a question of whether it was related to extrapulmonary TB or just pulmonary TB. So yeah, I mean, they're all forms of TB. There's no specific, but that's to say that there is very limited data, as far as I know, on extrapulmonary TB and diabetes. So the main thrust tends to be on TB and pulmonary TB, but there is definitely a push for the need for operational research to increase this, to improve these, you know, to strengthen the evidence. Tony, perhaps you'd like to add to this. And I think also there's the MDR TB. There's definitely an association between MDR TB and diabetes, just in relation to the previous question, which is, you know, could in part be due to poorer treatment outcomes. So there is actually, I think, is a almost double risk of relapse. So, which I put in one of my slides. So I think, you know, that could feed into drug-resistant TB. But Tony, maybe you would like to add to that. Over.
And Tony, would you like to add to what Annabelle is saying?
Yes, no, I'll add to that. Thank you. No, Annabelle's quite right. That's
okay.
Sorry, big echo here. So basically, I think the studies have shown that diabetes increases the risk of primary TB drug resistance. Yeah, I'll stop there.
Okay, thank you. There's another question that maybe, Annabelle, you can respond also. It comes from Cambodia. They say the world is moving to end TB by 2035. However, the trend of diabetes is increasing, and diabetes are 2 to 3 times more likely to develop TB. Are there any specific strategy to prevent TB among diabetic patients, such as TPT? Over.
Thank you. What a nice question. Well, I think, you know, Brazil was showing that how they're looking to do that. And in the latest TB preventive treatment guidelines, it does not actually recommend systematic screening and treatment of TB, management of TB latent TB infection amongst people with diabetes. But it's that is really because of the limited data on the impact of TB preventive treatment on people with diabetes. So that's really, again, I'm afraid, another invitation to strengthen the evidence and really promote more work like Brazil is doing to really, try, see. I mean, there are some countries that are particularly much more at risk, and especially in the Latin American countries, and and also in parts of WIPRA and Sierra. There's real. There could be some great possibilities for scaling up and trying. Doing some operational research on TB preventive treatment to perhaps inform the next guidelines. Thank you. Over.
Yes, Annabelle, thank you very much. There's another question now for Dr. Qadir. They ask, do national guidelines in Pakistan recommend bidirectional screening for TB and diabetes mellitus? What is the implementation coverage? Over.
No, currently there is no guideline of bidirectional screening. For MDR TB, we are doing the screening of diabetes in MDR patients, but in the sensitive TB, it's not in the guidelines yet.
Any plans, Dr. Qadir, to do that in the near future?
Well, it all depends on the resources. So if the resources are available, then the TB control program might include it.
Okay.
Pakistan is a big country having more than 2,000 sites, and providing the facility of diabetes testing in 2,000 sites will be a challenge for the program. But for MDR TB, yes, it is in place, and we are doing it. Okay,
thank you very much. Now, there's another question linked to the previous one for Denise Arakaki from Barsha Thapa. What would be the reasons assessed for having more TB diabetes in women as presented in your study? Over.
Okay, just to clarify, it's not a study, it's a regular activities in the routine care on the primary health care. It's not a study what I presented. And the hypothesis to have more women is because women goes to the programs more than men. And because the healthcare facilities are open during the day, and many times the men don't have access to this facility. So our hypothesis is the woman is more adherent to care. But because we don't believe in another biological reason, we believe it because the access to the care.
Okay, thank you very much, Dr. Denise. Now I hand over to Professor Harris to continue with some other questions we have in the Q&A. Tony, over.
Yes, thank you, Rafael, very much for that. So I've got a number of questions here. So maybe I could start with a question from Yupei Xiao. And this is to you, I think, Denise. Could you comment on the value of latent TB infection screening in people with diabetes? Would you think this is worth considering for better TB control in diabetic patients in the future? Over to you, Denise.
Okay, thank you for the question. It's a challenge for us because as I showed, the TB is increasing, and TB is a very solid program in Brazil. And more than 50% of the Brazilian population are over 80. So we don't have a malnutrition. We have the overweight problem. And in the future, maybe we will have obesity as a big problem. So I think it is valid to screen TB in diabetes people. And now with the data, we are implementing the LTBI. LTBI for TB is now our national recommendation. And maybe in 2 or 3 years, we can focus the screening for TBI in diabetes patients. Maybe we don't need to screen every diabetic patient. Maybe you can focus on women or in elder people or people with obesity or metabolic syndrome. But we are very aware about this data, and the surveillance on TBI in comorbidities is very recent for us. So, but I think in the next year we can define how and who should be screening for TB in comorbidities.
Right. Thank you very much. Thank you very much, Denise. So let me ask another question. This is from Saw 10. She wants to know whether we should have glycated hemoglobin or both random blood sugar and glycated hemoglobin for diabetic screening. And I think maybe Dr. Aurangzeb, I could ask you from Pakistan, would you like to try and answer this question? What is the best tool, essentially, for trying to screen patients for diabetes?
Well, glycated hemoglobin will be better to know the status. So HbA1c, so I will recommend that rather going for random or fasting blood glucose, so glycated hemoglobin level will be better. So to have the record of the levels of glucose in the blood, so I will go for this. Thank you.
Right, thank you very much. I'll continue because there's quite a lot of questions here. So this is from Sayot Hasanova asking about funding opportunities for basically addressing the comorbidities of HIV, diabetes, and TB. So I think, Mohammed, this comes your way from the Global Fund. Do you think this could be well addressed to countries? And do you think Global Fund would support countries in basically screening for diabetes, HIV, TB together?
Yeah, thank you very much. Very good question. And for TB, HIV comorbidity, I think because both are supported by Global Fund, we are probably in more advanced stage where we have been promoting, to integrate service and joint programming, even joint funding requests. Yes, I think now diabetes, I see that the information evidence we have is still, at probably earlier stage, and but the opportunities are there, and Global Fund encourage countries to move to more integrated approaches and synergize their efforts and consider comorbidities which would affect TB, HIV, and malaria. And that's where investment and support for diabetes, screening people with diabetes for TB and HIV would be in line with overall Global Fund priority interventions. But the request and the evidence and that prioritization is more country-level discussion, given that the available resource, both from domestic and from Global Fund and other donors, may be limited. That's where prioritization would be important, and evidence and data, some of the studies would be very important to inform that prioritization. Otherwise, this will be probably in line with the Global Fund overall investment, and there would be opportunities to support comorbidities. Over.
Right, thank you very much, Mohammed. So Annabelle, I missed it. Did you deal with the question about WHO report or NTPs reporting to WHO about diabetes and TB screening? I'm not sure Raphael asked that. So if he didn't, let me just ask you. So basically the question, this is from Ajay Kumar, is, do NTPs routinely report on their performance with diabetes TB to WHO? If so, I can see you shaking your head, but if so, what is the extent of coverage? And if they don't report, why don't they report? Why shouldn't we make this an important indicator?
Ajay, that's a brilliant question, and it's a really important question. And I mean, this is just, you know, the crux of it. Basically, TB and HIV, we know how much it has, you know, how much it's been scaled up, and I think partly because there have been indicators that we have collected globally, that's driven the scale up. So I think, you know, we need to be thinking about this in the, as I was saying, we're sort of putting together a framework for action on TB and comorbidities. There are indicators that are recommended at a national level. One has to be, there's always this tension between, you know, asking for too many indicators from programs because there's a lot to ask. But, you know, this is something that, you know, I personally would really like to get there as something that can be used. I mean, it's really great to see that there are programs in those high burden countries that actually have got indicators, but WHO doesn't ask for them at the moment. I think Euro does. WHO globally doesn't, and so, you know, hopefully that's on the list of things to do. Sorry. So yeah. So that's me, over.
Yes, no, thank you very much, Annabelle. So in fact, there's one other question from Dr. Kumar, and that comes to you, Aurangzeb, about do the national guidelines in Pakistan recommend bidirectional screening for diabetes and TB? And if so, what is the implementation coverage nationwide?
Thank you. As I told you earlier, in the earlier question, it was the same question that for DRTB, it is recommended and it is implemented. For DSTB in the national guidelines, it is not yet incorporated. So unless we have the facility of testing the blood glucose at the facility level, we cannot implement it. So it's not for the sensitive TB, but yes, for the DRTB, it is there in the guidelines and it is implemented everywhere where there is a DRTB facility. Thank you.
Thank you. I think I've got a question from Pius Ongareno. It's a good question. He's saying essentially in most low-income countries, we have parallel services for tuberculosis and of course for diabetes and for NCDs. So he wonders what are the guidelines really try and harmonize this situation, and how do we deal with it? And I saw in your presentation, Annabelle, that if you look at the TB side, we are doing reasonably well with trying to integrate diabetes. But if you look at the other side, look at those national strategic plans, we're not doing very well. So maybe you'd like to address that, Annabelle, and I wonder if Charles, who's been working on this in Zimbabwe, would like to come after you. Annabelle?
Okay, I'll try and be brief. I think, you know, that's really important. You know, with TB and HIV collaboration, it's been really a collaboration, and we have to have the sort of joint programming and the working together. And this is how the diabetes side should be working. But I think, you know, there's the NCD programs, sometimes they're not programs. And I think this is where it may be trickier in countries that, you know, you may not have such a stronger kind of priority and therefore as much funding for that part of the Ministry of Health. And so it's perhaps a less so an unequal partnership. I think also looking at the NSPs, they were less action oriented. So I think we need to work closely with them and basically, you know, and work together with the NCD department in WHO and, you know, sort of really get this collaboration and try and sort of do the, you know, sort of top down and bottom up and see how, you know, try and hone it and perhaps use the TB and HIV model as something to duplicate, and also as part of strengthening of primary healthcare. And I think that's another key thing that we should be getting out of this. Over.
Yeah, thanks. Charles, do you want to quickly comment on this? Just a brief.
Yeah, sure. I think it will remain work in progress. There's always a challenge in bringing on board our other colleagues that should not give up. And I think having TB, HIV guidelines helps. Also having TB, HIV integrated guidelines will also help. And then ensuring that during sensitization and orientation, you are including the other programs which will then assist.
Right, thank you. I'm going to hand back to Raphael. I think you've got a couple more questions. We've got a few minutes, Raphael, so we'll have to be quick, I think.
Yes, thank you, Tony. Yes, there's another question from Fernando Sanchez, and this would be to Denise. Regarding the link between diabetes and TB, is it possible to address those information to occupational status, mainly to healthcare workers? Beneath these, diabetes mellitus could be think of an additional risk to developing latent TB infection or TB disease? Denise?
Yeah, Fernando, thank you for your question. I know Fernando and I know he is working hard on professional healthcare workers, and it's possible we have this data, who has LTBI and in which category the person belongs. For example, we can stratify by occupation, so we can, but we have to link the database. The LTBI database is not the same as diabetes database and TB database. So using the linkage, we can get this data.
Thank you, Denise. There's another question that is probably Dr. Charles. Are TB diabetes indicators now included in the National Health Information System in Zimbabwe?
Yes, we have included some of the indicators in the GHIS2, which is our reporting tool. So yes, we have managed to do that, and we can gather the information on a quarterly basis.
Thank you. There's another one that is most probably a comment. It says, it is interesting to observe that people living with diabetes mellitus are more engaged in their treatment than people living with TB. TB programs should learn from diabetes. And there's another one, a question saying, started TB medicine after a few months, then they get diabetes. Any reason to explain, please? I don't know who would like to take this question. Annabelle, would you like to take it?
Please, can you repeat? I didn't quite get.
Yes, so there's someone asking, Aksar Arif, started TB medicine after a few months, they get diabetes. Any reason for this?
So we're talking about, I suppose there's a temporal a pre-diabetes, and I think, you know, that it generally shows that I think there's a sort of tuberculosis gives rise sometimes to raised glucose levels, and generally it can be addressed through treatment, but it needs to be watched and it needs to be monitored. So yeah, I think that's the best I can say. I don't know, I'm not sure exactly of the reasons per se, but that's the best I can do on that one. Okay.
Great. Thank you very much. I'm handing it to Tony to close these sessions as we are arriving to end of it. Tony, over.
Yeah, no, thank you, Raphael. So, Raphael, I'll just quickly sum up and I'll let you do the thank yous. So really, I hope everyone listening in is at least convinced about this interaction between diabetes and TB, TB and diabetes. I think from this session, I take in the great work being done by your team in WHO, Annabelle, at the country level in Pakistan, in Zimbabwe, and in Brazil. And it's very nice, Mohammed, to hear that the Global Fund is beginning to consider multi-morbidities as a sort of general package for TB care. To me, I think the challenge will be to get the diabetic community on board to address TB. I mean, I think as we all probably know as clinicians that the diabetic community is interested in cardiovascular disease, ulcers, peripheral neuropathy, etc. But I think in high burden TB countries, we've got to start this process of making them think TB is an important complication and needs to be screened for, even if it's targeted screening, for example, like in diabetics who are thin, who perhaps might have TB. Raphael, I'll hand over to you to just do the thank yous.
Yes, thank you, Tony. Yes, I would like to thank all the presenters, to Tony, and to all the ones that participated in this symposium. There have been very interesting questions. This is a very interesting topic that we have to continue moving forward and getting more evidence. So thank you again, and we will continue discussing these topics in this conference. Goodbye, everyone.